All right. Without further ado, good afternoon, everyone, and welcome. My name is Amanda, and I'm DWDC's program coordinator. Today, I'm joined by my colleague, Taylor. I'd like to first start by acknowledging that the land on which we gather today is the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. These nations continue to experience ongoing colonization and displacement. And today, Toronto is covered under Treaty 13 and the Williams Treaties. Dying with Dignity Canada is also mindful of broken treaties that occurred across Turtle Island and recognize our responsibilities as treaty people to engage in a continuous process of truth and reconciliation with all peoples across this land. I'm very thrilled to welcome you today. Through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life topics alongside the professionals that know it best. Before I welcome today's speaker, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities for you to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. In the interest of time, we ask that you try to keep your questions as clear and concise as possible. We'd also like to address a common theme that we received in our registration questions for this webinar. Many of you submitted questions, over 300 in fact, asking about medical assistance in dying and advance requests. Now, I do want to clarify that for this session, Dr. Sheets will graciously cover the early progression of dementia-type disorders and how patients can build their network of support. But I do want to highlight that MAID is not going to be the focus of this webinar. And just 2 weeks ago, CEO Helen Long and our Director of Programs, Kelsey Goforth, hosted an Ask Us Anything style session that covers many of the topics and your questions in that session. So, with that in mind, here's a quick reminder. Advance requests for medical assistance in dying are not available anywhere in Canada except for the province of Quebec. If you're interested in learning more and getting involved in the fight for advance requests, we strongly encourage you to visit our website. And don't forget to check out our letter writing tool, which makes it easy to send a personal email or a letter to your Member of Parliament and the Ministers of Justice and Health. Furthermore, having a dementia type diagnosis does not automatically disqualify a person from having an assisted death. We've heard from many audience members who want to know that if having a dementia type disorder, like Alzheimer's, means that a person cannot have MAID. Some people with dementia have been able to access MAID since it became available in 2016. And of course, if you're interested in learning more about this topic, aside from our webinar 2 weeks ago, you can visit our website and access our fact sheet on the topic of MAID and dementia, in addition to the many other webinars we've hosted on this topic. Okay. So, while we are going to try to get to as many audience questions as possible, unfortunately, we may not get to everyone. If you have outstanding questions from today or want to discuss the topics that I just mentioned, you can email us at support@dyingwithdignity.ca, and we will follow up with you one-on-one. Please note that the session is recorded, so there's no need to take notes if you don't want to. And I do want to mention that there will be a follow-up post-webinar survey that will pop up on your screen after the webinar, and it gives you the chance to share your much needed and appreciated feedback. All right, and finally, if you'd like to make sure that you receive regular updates from Dying with Dignity Canada on upcoming webinars, events, advocacy initiatives, make sure that you're subscribed to any of the social media platforms that you can see here on your screen. We're also going to be including a link to our newsletter, which you can sign up for in the chat. Okay, and now to introduce today's speaker. Dr. Debra Sheets joins us from Victoria, BC today and holds a doctorate in gerontology and public policy, as well as fellowships with several national and international academies, including the Canadian Academy of Nursing and the Association for Gerontology in Higher Education. A leading expert in aging with dementia, care partner support, and healthy aging, Dr. Sheets is also the founder of Memory Connections, a nonprofit organization that creates memory cafe programs, offering arts, music, and recreational activities for people living with memory loss and their care partners. So, Deborah, thank you so much for joining us today. You've graciously prepared a presentation for us in advance, so I'm going to go ahead and pass the floor on to you now.
Good afternoon, everyone, and thank you so much. Let me just put this into my slideshow. Okay, pleasure to be here this afternoon, and I hope that you're managing to be at home and not out there digging out from this storm, that you fared well through this very cold weather. It's a pleasure to talk with you today about something that I think is really a growing concern and a big public policy priority, dementia. And how to navigate a dementia diagnosis will be my focus this afternoon. So, in short, what I'm going to cover today is normal aging versus dementia. So, what are the early signs to look for? What are the risk factors? Because we all want to know how to reduce our risk. And then we'll get into after diagnosis. What are the initial steps that people can take? What are the priority decisions and planning that need to be done? And it is very important to do some of that early on. And how do you build a care network? What are the resources that are out there to help you with that? Lastly, I'll conclude a little bit with living well and some of the research that is really changing sort of the landscape of dementia and some of the resources you can turn to. And then I look forward to hearing what questions you have after I go through some of this. I just wanted to begin briefly by talking about dementia prevalence. It's definitely accelerating exponentially. By 2030, we'll have 1 million Canadians living with dementia. And every day, over 414 Canadians are diagnosed. Now, most of these are women because the most common form of dementia is Alzheimer's, and women live longer than men, and Alzheimer's disease is definitely age-related. The prevalence of Alzheimer's increases, it doubles every 5 years. So at age 65, about 5% of people have Alzheimer's disease, but by age 70, it's up to 10%, and so on and so forth. In addition, dementia is a disease, it's a condition that affects women in particular, because more than half of all care partners are women, whether they're adult children or spouses taking care of their partners. In addition, I just want to note that ethnic minorities, African Americans, Asians, Indigenous groups are disproportionately affected by dementia prevalence. This is in part because of the cumulative effect of socioeconomic disparities, which place them at greater risk. So things like having access to higher education, access to healthcare, things of that sort. Okay, so what are the early signs of dementia and when should you be worried? Well, first of all, there's cognitive changes that happen with dementia, memory issues, in particular forgetting recently learned information or important dates, needing more reminders. So people start writing things down a lot, but then they can't find those reminders. There's also language issues. There's a number of different types of dementia that affect language more than other types. And people start struggling with common words, or they'll substitute unusual ones, or they'll say that thing over there instead of saying, that glass. They may have trouble following conversations because of these language issues. And they may also stop in the middle of a sentence or not be able to carry on a conversation as dementia progresses. Money management is often an early indicator of some of the cognitive changes because that's a complex executive skill. So if someone starts struggling with managing their bank account, balancing their checkbook, of course that can happen at any stage, but if they've been able to manage their bank account, new problems managing money, paying their bills, paying bills twice, making errors with money management things, these can indicate challenges, and they may also make poor judgments about spending money. So people become more vulnerable to scams and things of that sort because they just don't recognize them. Impaired judgment, people start having difficulty with decision making. So they may dress inappropriately for the weather. They may, again, make poor financial choices. There may also be some disorientation at times, in particular, losing track of dates or booking something for the wrong date, getting lost in previously familiar situations. And lastly, problem solving and planning. So people may struggle with complex tasks like planning activities, planning family get togethers, things that used to be fairly straightforward. Another early sign might be behavioral or mood changes. People can become typically more apathetic with dementia. They may have increasing anxiety and may also have an increase or an onset of depression. Um, in particular, apathy is very common, and people with early dementia need encouragement to get out and stay engaged in activities because that's really important for their quality of life and longer term well-being. But we often do see social withdrawal because people have trouble more in social situations. They may not remember someone's name. They don't want to be embarrassed. And dementia has a lot of stigma and people treat you differently as well. So people often withdraw if they've had a diagnosis. There may be some personality shifts. People get frustrated when they can't remember things. They may get more irritable. And this is something that can be easily managed if people do get diagnosed and their doctor's made aware of this. My dad had dementia for about 17 years, and my mom was very concerned about medications. But the best thing that happened to him was when he went on an antidepressant. He wasn't depressed and he wasn't as frustrated, and it didn't sedate him. It wasn't something that really put him out the way she was concerned. So concerns like that can be addressed, and these medications can actually help people have a higher quality of life. People may also become a little bit paranoid because they can't find things, and so they can become suspicious, like who took my keys, or where's this piece of jewelry that was in the store previously. And often it's unwarranted, and you'll find these items in other places, but it's challenging to deal with that paranoia. Other early signs are when someone's having trouble with familiar tasks, like daily routines, like preparing a meal or cooking, which they've always done previously. Trouble bathing, they may stop bathing as often because they don't, they aren't as comfortable in the shower. They may also have visual spatial problems, and this is why it's really important to have people assessed for driving because they may have difficulty judging distances, they may get lost. So this atrophy in part of the brain causes difficulty processing visual information. It can also cause falls or, difficulty with colors as well. It really, really depends. And as I mentioned earlier, people may lose or misplace items and be looking for those. It can be difficult in particular for people with early dementia to retrace their steps. When we misplace our keys, we think, okay, where did I last see them? And we start retracing the rooms we were in or what we were doing. But that's something that doesn't happen easily when you have early dementia. Dementia, 60% of people think that it's 65% of people consider Alzheimer's disease a normal part of getting older, but it's not a normal part of getting older. People may have trouble remembering as quickly, like I'm 68. I've had that experience of I can't remember a name and then of some actor or something, and then a few minutes later it comes to me. That's a typical age-related change, that little bit of forgetfulness. Being able, as I said, to retrace your steps when you can't find something, making minor errors, like adding up numbers and not coming out quite right, or forgetting how to do a certain math issue. That's age-related changes. But signs of dementia, well, there is persistent decline in the cognitive tasks. It disrupts daily life. So being able to manage activities of daily living, which are things like bathing and cooking, eating, daily tasks, managing your life. And there may be some disorientation and again, behavior changes. So those are signs of dementia versus age-related. So definitely the key distinction is that you need at least decline in more than one cognitive area that affects daily living. So that helps us a little bit distinguish between age-related changes and signs of dementia. Okay, so after diagnosis, what are the first steps? Um, it's really important that you clarify the diagnosis. What is the type of dementia, if they can give you that answer? You want to rule out reversible causes because there are some causes of memory loss, such as a vitamin B12 deficiency, um, that can be reversed. But a lot of dementia is progressive, and it's really important to get it diagnosed early. So dementia is a overarching umbrella term for a lot of the different types. Um, I'm going to show you some, I'm going to talk about some of those types in just a minute. You want to establish a care plan early on so that you've got a sense of what are the priorities and what are the needs going to be going forward. And in particular, it's really important that you start addressing safety concerns. Um, People may not initially have driving problems or difficulty managing meds. They may not be wandering, but those things can come up and you want to be prepared before they do. You want to have someone assessed for driving regularly. You want to have a plan in place so that people aren't double dosing their medications. And if someone is out in the community, you want them to have identification so that if they can't find their way home, that somebody could help them or call the care partner. And another first step includes connecting to supports. So again, getting your supports in place and knowing how you can provide support for the person living with memory loss and also the care partner, because the care partner is going to be a key part of how things go going forward. So I mentioned dementia types, and that dementia is an umbrella term to describe a range of symptoms that occur with cognitive impairment. And Alzheimer's, of course, is the most common. It's age related. It typically occurs, it becomes more prevalent in the mid 70s and 80s. After about age 80, it affects about 30 to 50% of older adults. But vascular dementia is also quite common. And that is a type of dementia that's affected by cardiovascular factors like mini strokes that can kill off parts of the brain. So it may manifest differently than Alzheimer's depending on what parts of the brain have experienced a bit of a brain stroke, a brain attack, I think is what the Stroke Association is calling it. Um, so, and then there's Lewy body dementia that affects about 10 to 25%. And this often affects um, people in ways that cause some behavioral issues. And it's caused by a buildup of abnormal proteins in the brain. Frontotemporal dementia affects the part of the brain responsible for personality and behavior. So frontotemporal is about 10% of people with memory loss, and that can really result in some personality changes. Now, there's something called LATE that's just been in the news lately, and I want to mention this because this is an acronym for limbic predominant, this is hard to remember, limbic predominant age-related TDP-43 encephalopathy. It's easier just to say LATE. It's a newly defined form of dementia that affects primarily people over 80, and it may look like Alzheimer's, but it's caused by a buildup of a specific type of protein, TDP-43, rather than amyloid proteins, which are associated with Alzheimer's disease. So it causes a slower progressing memory loss and cognitive decline, and it's often misdiagnosed, and it's been in the news a lot lately. They're thinking now that it may affect about 15 to 20% of all dementia cases, and that about 50% of people with Alzheimer's may also have late. Now, if you have a combination of these, if you have a mixed dementia, like it's very common to have vascular and Alzheimer's, because people often have heart disease along with being older and coming down with Alzheimer's, this can affect the progression rate, the trajectory, the problems that occur. And late combined with Alzheimer's can progress more quickly, but on its own, late dementia progresses pretty slowly. And so it's actually a better diagnosis if you only have late and don't have Alzheimer's. So it's a complicated thing, Alzheimer's. I mean, having dementia. And that's why they say if you've met one person with dementia, you've met one person with dementia. You don't know all the details. Trajectories of decline and the care needs can be very different depending on what what the impact has been on that person, whether it's personality, whether it's executive functioning, all of those things. They need different supports in place. Um, Most of us want to know, like, how can we modify our risk for dementia? Um, and there are 14 things we can do that have to do with lifestyle and health that can reduce our risk. So, in terms of health, if you have high cholesterol, getting that treated is very important. If you're diabetic, having your diabetes managed effectively so that you're not spiking high blood sugars, and we've gotten a lot better at managing diabetes, is crucial. Obesity, maintaining a healthy weight, reduces your risk. And of course, if you've had traumatic brain injury and concussion, actually, you can't modify that too much, but it's important to know about so that you can get treated if you've had a concussion and that you can be monitored if you've had a TBI. It's called a traumatic brain injury. Physical inactivity is a significant risk factor. We all know that what's good for the heart is good for the brain. Being sedentary is bad for the heart, consequently increases your risk for cognitive issues. Sensory and vision, oh my goodness. Hearing is one of the biggest risk factors. Hearing loss is one of the biggest risk factors for dementia, we've realized. When people don't get their hearing addressed with hearing aids, the amount of risk like doubles. When you have mild hearing, it's like 10%. And if it's moderate hearing loss, you're up to like a 30% higher risk. And if you have severe hearing loss, it's like a 50% risk. It increases your risk for dementia. And vision equally. And it makes sense, doesn't it, that when we have less sensory input, that our risk we're having less stimulation to the neurons in our brain, and that may increase our risk for hearing, for memory loss, for dementia. There's also lifestyle factors, smoking, alcohol, getting enough sleep. Smoking and alcohol, recent guidelines, we know that smoking is not good for your health. Alcohol guidelines have really changed. They're now saying any alcohol isn't good for your health. But for men, it's like 1 drink a day. And for men, it's 2 drinks a day at most. And for women, 1 drink a day, and ideally none or a lot less. There's social factors that really impact risk for dementia as well. And people who are socially isolated, who have very few social connections, are at higher risk for dementia. As well, untreated depression and having lower education levels. Having more education just increases your cognitive reserves, and that's why people who have high levels of education can often hide any declines in cognition. They test better longer because basically that education covers any cognitive decline for a while. There are also environmental factors. If you live in a very polluted area, that can increase your risk for dementia. If you're diagnosed with dementia, it's really important that you begin to empower yourself to make some choices. You need to build your support network. And how do you do that? You talk with family, you talk with friends, you reach out within your community to different organizations that I'll mention in a little bit. You also need to dive into some legal and financial planning. You need to begin thinking about a durable power of attorney who can manage your financial and legal affairs if you become incapable. You probably want to have a will and a testament. I mean, we should all have that, just to ensure that things go well in case something happens to us. But it's particularly important while you still have cognitive capacity to go ahead and make a will. And you want to have a chance to have those difficult conversations with family about your preferences for long-term care or for staying at home with support versus moving to a facility. Most people want to live at home as long as possible. And so to begin to do some of that planning to make that possible, that can be empowering. You also want to get a driving assessment done to assess whether or not you're still safe to drive, and also to begin to talk about when you're going to surrender your license and when safe driving is no longer possible. Advanced care planning documents are really, really important to do, and you want to also talk with your family about defining the goals of care. What is it that you want to avoid? What kind of care do you want in place? So documenting those values and wishes and stating, having your family be aware of what constitutes a quality of life for you, because we're all different in those areas, is really crucial. Um, and again, just to come back to legal and financial, be sure you identify a substitute decision maker with a power of attorney, and also advanced healthcare directives. These legal things are really hard for people to get moving on. I mean, I think of people, the numbers for people who are in their 80s who still haven't done any legal or financial planning. We just don't want to think about that day when we can't manage our own lives, and it's so important. This picture to your right is actually a group of people that I'm working with. I run a program for people living with young onset dementia. And this is a new group of people with dementia. It's a rare type of dementia. It affects people under age 65. I've seen people as young as 45 with dementia. And they are so different from the older adults with more typical dementia who are in their mid 70s and 80s. These guys want to stay active. And so I've had to create a whole different type of program for them. We go out canoeing, we go out hiking. They're young, they're fit, and it's devastating to get this diagnosis at that age. But unfortunately, it's becoming more common. And it's not that it's common to get that diagnosis. It's not, I think, that it's more common to have dementia at an early age. It's that we now have testing and ways to diagnose it that have gotten better. And I'll talk a little bit about that. But in particular, people who were young used to get told, oh, you have too much stress from work, or, oh, you're depressed, or, there's all these other reasons. And they weren't testing them cognitively to see whether it might be a type of dementia. And now that's happening. And now we need to start creating programs that are appropriate for them, because they have quite different needs and preferences than people who are 75 and older. So I just wanted to mention that, because that picture, we went out canoeing, and they really like being out in the community and doing activities that are meaningful to them. Post-diagnosis, there's a number of challenges. In particular, the emotional impact of a diagnosis is huge, right? I mean, people dread, there's so much stigma with dementia, and people just, it's a devastating diagnosis to get, and they need support. Of course, a key challenge can be cognitive decline. The trajectory can be different depending, and you don't know, and people want to know, like, what can I expect? But it can be a bit challenging unless they're able to figure out what type of dementia you have. And even then, it can vary depending on other factors, personal factors like your educational level, other factors that affect it. Of course, there can be some behavioral changes, and this can be particularly hard for care partners to see their loved one changing, getting more irritable, having some personality changes. There's also the issue of caregiver burden, and care partners, care partners need to begin to plan and make sure that they're including respite, and that they've got other family members who are helping give them a break, and that they are getting help where they can, because care partners take on so much when a diagnosis like this comes down, and over time that the level of things they have to manage. They used to have a partner or other family members that helped them with the finances, with the household maintenance, with family events, etc. So it can really cause a lot of burnout over time. The typical caregiver for someone with dementia is providing about 26 hours of support a week. They're much more likely to suffer from depression and burnout than someone who's coping with a more physical type of disability. Cognitive disability, cognitive diagnoses are the hardest, have the biggest impact on care partners. I would say that one of the most important post-diagnosis challenge is trying to find the right caring community that's supportive and inclusive, And in particular, sometimes friends fall away when they find out that you have dementia. They There's a lot of preconceptions about dementia and decline, and people drop away. And the picture on the right there, I run memory cafes for people living with memory loss, and we try to create a space where people can have fun, connection, and learning. And this was memory boxes that two of our members created. They brought in some personal things, and we provided the boxes, and they created a little box with some of their favorite things. In this case, Rena really loved music, so she's got music on the left door there, and personal things to remind them of the things that they love and enjoy. And it's so important. Our care partners come with the care recipient. We want them to step out of caregiving. They get a little bit of respite, they get to have some fun. And importantly, they meet other care partners who really understand what's going on in their life, because not people don't understand till they're going through it often. And the person living with memory loss, they meet people with memory loss with similar challenges and who also want to get together. And often our memory cafes, couples have met outside of the memory cafe to go out to dinner or to, go for a walk and just, find that support from other people. And it's not that easy to do unless you unless you can find a group like a memory cafe, or our Alzheimer's Society here in BC is now offering a coffee and chat, which is kind of similar to my memory cafes, except the focus isn't on arts, it's mainly on chatting. Um, by the way, so caregiver support groups can be helpful, but here's something I heard just this week. The people with young onset dementia said it's so depressing to go to a support group where it's all older people because of the different stage in life they're at. And sometimes the dementia has progressed to a point that they're not ready. They find it depressing to be in that support group. So there's some efforts underway now to create young onset dementia support groups. And I'm so glad to see that, because they need to be, there are differences among these groups of people based on when dementia occurs in their life course. A really important thing, a really important challenge post-diagnosis is meaningful participation in something that matters to you, whether that's gardening, being involved in a choir, exploring art, but meaningful participation, because often people end up in an adult daycare program 1 or 2 days a week. And those are more time fillers meant to give care partners some respite. And particularly for people with young onset dementia, they don't want to go. They don't find it, they find it really not enjoyable. And I think they need a different type of program. But people who are older, who have Alzheimer's disease, also often tell me that the adult daycare isn't very interesting. And I mean, adult daycare, they do the best they can, but it's not as personalized. It's not oriented towards people's interests. And so one of the things I'm trying to do in my community is connect people with things like, we have a men's shed. A men's shed is about men getting together to do manly things, like they build little free food banks for the community where people can donate food, kind of like the little free library idea. But trying to make connections and go out and talk to these groups. Our men's shed here in Victoria, I met with them. They were very nice. One of our guys likes to play cribbage. He doesn't drive. Once I explained to them that he doesn't drive and he loves playing cribbage, they found one of their members that would give him a ride and bring him out to play cribbage. So it's kind of trying to provide that personalized navigation as well. And we don't have enough of that. It's called social prescribing, is a general term. But people with dementia really need that kind of support, that personalized approach. Okay, I want to talk about one of the challenges is the need for care over time. 85% of dementia are going to live at home in the community, and they receive the majority of their support from family. 58% of care providers are children. Whoops, I don't know why that jumps. and 32% are spouses. And then there's also family and friends that can provide help. Now, the impact of dementia is often on activities of daily living, eating, dressing, personal hygiene. They need support with that. Care partners are sometimes reluctant to use to get some home care support. I know my mom thought that only she could provide my dad with the activities of daily living, like getting him into the shower to get him bathed and helping him to do that. And it's really more important for care partners to be there for the emotional support than some of these daily activities. So I try to encourage care partners to really think about, like, what is it that someone else can do well? I was finally able to talk my mom into getting a home care aide in to help my dad with bathing. He was getting more resistant to bathing, and it was really a struggle. He didn't like the water. He was cold, and she could barely manage it. So this young home care aide arrived, and it was somebody new. And she said, "Let's go take a shower." And he followed her down the hall, and my mom was amazed that he just like went. It was somebody new. He was happy to take a shower with her there, helping him. So there are things that care partners can delegate out that they don't have to do. And depression, up to half of people with dementia, with memory loss, show apathy, irritability. They often have sleep disturbances. They may have sundowner where they get more confused as night comes. These are things that the doctor needs, your primary care medical provider or your neurologist needs to know about. And particularly the irritability, the sleep disturbances, because they really impact quality of life. And an antidepressant and something to help with sleep even can make all the difference. So it doesn't have to be about sedating someone so that they're not responsive or anything. That's not the goal. The goal is to help them have a higher quality of life with some judicious medications. They say start low and go slow with older adults in general. Behavioral changes too affect about 25% of people with memory loss. And so managing those and keeping people safe is crucial. And making sure that if they get lost, that you've got a way to track them. Okay. Care partner health and stress. I just wanted to come back to this because care partners are crucial to the care of the person living with memory loss. Here in Canada, there's over 350 care partners. They save billions of dollars. They provide millions of hours of caregiving. It jumped ahead. I wasn't even touching. By 2050, there'll be over 1 million care partners, and they provide just 1.4 billion hours of care. 45% of care partners of people with dementia show symptoms of distress and strain. This is nearly double that of caregivers for other health issues. And so caregivers need to be aware of the risk for this and to try to mitigate it and to prevent it by accessing resources and knowing that this is a key risk for them. And it often impacts their health. Like care partners can die before the person living with memory loss, because one of my colleagues had a heart attack while being a caregiver. She didn't die, but care partners do die because of the stress. So I can't say that enough. There are some family support strategies that are worth talking about. You may need to simplify your communication, break things into simpler tasks. You need to validate feelings, not correct people all the time, but say, I understand you're upset about that, and then try to distract. You need to pay attention to nonverbal cues because people with memory loss are not able to articulate as well. And so you can tell a lot by their facial expression, by their body language. It's important to provide a safe and consistent environment, a daily routine that people can expect, and to do this daily life management. I would say make sure that they're set up for bathing. Let me see if I'm missing anything here. And also that you have caregiver support. Okay, there will be some care transitions over time that people need to anticipate, and the key areas are listed here. and that require attention. So safety, issues of wandering or getting lost. Um, and yet we want people to stay independent. So if you have public transit programs, it's important to use those to help people to get to programs that keep them involved in their community. There's mobility risks. People can have more falls or difficulty walking. Pay attention to any cognitive hazards that you notice, like people leaving appliances on, not paying bills, or scams, piles of mail accumulating. Personal neglect is also an issue. Poor hygiene or soiled clothing, not wanting to take care of themselves in terms of their personal care. On a nutritional level, people may have weight loss or spoiled food. You may be having food delivered to your parent, but have you checked the refrigerator to see if it's spoiling? That was something that happened with both my grandparents. They had Meals on Wheels and food was being delivered, but there were bags and bags of food in the refrigerator. They didn't know how to use the microwave, and they weren't cleaning out the refrigerator. Clutter can also be a sign that there are some transitions going on that need to be addressed. You need to get in some home care support. Urgent red flags, of course, are medication mismanagement. And so early on, you may want to look at how medications are being managed and if they're in bubble packs so that people don't double dose. If someone's become very socially isolated, they're not getting out of their house. Or if there's any driving incidents, like there's dents on their car, they got lost. Yeah, so okie doke. Okay, I wanted to talk a little bit about current and future therapies because there's some exciting things happening in the landscape of dementia that are a bit promising. And we've got some new blood-based biomarkers that should be available in the next maybe 5 years or so, maybe sooner. One of those is the p-tau 217, which offers almost 90% accuracy, which will enable faster, less invasive, and more accessible early diagnoses. Now, right now, we're relying on spinal taps. Those are quite invasive. They're quite uncomfortable. They sometimes require 2 or 3 attempts, and people have to. I've assisted with some spinal taps, and they are not. They're invasive. So to have a blood test would be just amazing. And also, it would allow us to pick up dementia earlier because we now think there's this whole early latency stage before it actually impacts some of the indicators that I've mentioned. And if we can catch it earlier, then we can begin to intervene earlier with some lifestyle changes, get people engaged in some programs. So it doesn't have to be that kind of stigmatizing diagnosis that it is now. We do have some antibodies that are now being used, the anti-amyloid antibodies, like lecanemab and deconanemab. Sorry, I misspelled that, which show about a 22 to 30% slower cognitive decline in some patients. The challenge is getting those across the blood-brain barrier. And so they're working on some things. I'm jumping to my 4th bullet here, but there's some new technologies coming out. One's called a brain shuttle that is trying to deliver these medications for dementia more effectively because they don't often cross the blood-brain barrier very easily. And if we could sort of target it to the brain, it would have fewer side effects. It wouldn't be systemic. There's also something called ARIA-H. This is a way of monitoring for microbleeds in the brain that's appropriate for certain types of causes of dementia, like vascular dementia. But this is expensive and it's not easily accessible at this point. So we'll see what happens in the future. I just want to touch briefly, I'm watching the time here, on research gaps. And key research gaps are things like the fact that we know very little about the impact of diversity, such as ethnicity and gender on dementia. Most of the studies don't include or aren't set up to look at differences in dementia by these groups. And so we need to have more studies that take that into account. Um, we're trying to identify more diagnostic tools, these non-invasive biomarkers that would make us be able to diagnose earlier. Um, there's also a need for research that would allow us to predict the rate of change. And this is going to be complicated and a while coming. The thing people want to know most is, now that I've been diagnosed, what can I expect? You know, do I have 5 years of independence or 10 years? How fast are these changes, um, these pivots that I have to do going to happen? Um, and we don't have those answers right now. We really can't. People progress at different rates, but there should be a way. There should be more research on this going forward. And ultimately, the goal would be to be able to give people a sense of like what to expect in the future, how this diagnosis may impact their function and cognition. Non-pharmacological interventions, research is really needed on this. There has been a growing body of research on community-based programs that focus on strengths, and on particularly things like the arts and music, which focus on imagination and creativity, which typically isn't impacted by dementia. And I would say to you, these non-pharmacological interventions, like joining an intergenerational dementia choir, I founded one of those here in Victoria. We've got two of them now, one at UVic and one at St. Andrews. They're intergenerational. Having programs like music, like a choir, where people are learning new songs, where they're learning them in different languages, where they're partnering with a young person who can help them follow the music and learn three-part harmonies, not just singing in unison. These are things that really have an impact and have virtually no side effects. The choir study that I did in 2020 found that the rate of cognitive decline was half of what it would have been compared to national samples. And we weren't changing dementia. What we were changing were those risk factors. People weren't socially isolated. They were happy and having fun. They weren't depressed. It reduced anxiety. It reduced caregiver distress as well. So caregivers had more positive interactions with their family member as well. So these programs that, another program I mentioned the Memory Cafe. Caregivers learn so much in the Memory Cafe from other care partners, and they learn how to be in the moment, and they see their care partner in a different way. And these things impact the stress they feel. It impacts their care partner, who is able to regain a new identity when they see what's possible to create. Some of them are honestly amazed at the pieces of art that they create. And I should have put one in here just to show you. It's really good. They can be really proud. Stigma is the biggest barrier to living well with dementia. And there are a number of studies that are looking at how to reduce dementia stigma. One's called Flipping Stigma, and it's being done at UBC. But we need to get the word out that you can't make the kinds of assumptions about dementia that people do, and that people are capable. They rise to the occasion with the proper supports. People can do a lot if they're in a program that's inclusive and that focuses on their strengths. So living well with dementia, well, a key thing is finding joy, connection, and meaning. And we know now, a book just came out recently. It's about mattering. We all need to matter. And people with dementia often feel like they no longer matter. Sorry, a bit noisy there. It's really important that their emotional health needs get addressed, that if they have depression, if they have apathy, that we pay attention to that and get some support. Physical wellness also is key, supporting brain health through exercise and nutrition. So trying to maintain the best possible health. Third, maximizing independence, creating routines that simplify complex tasks, and reducing caregiver burden in particular. Living well requires that caregivers reach out for respite and use it, that they get help from others, and that they engage in self-care to prevent burnout. So some of the resources that you should think about if you have a family member with dementia or if you're coping with this yourself is to reach out to the Alzheimer's Society. They have a referral program that's specific to local communities. That second bullet should have been edited out. There's also a number of caregiver organizations here, and they're usually provincially based. So here in BC, it's Family Caregivers of BC. I think in Ontario, it's Caregivers of Ontario. They can be really helpful. They often run support groups, they offer education, um, and they work closely with the Alzheimer's Society as well. There are helplines like 211, which can refer you for community services like home health care, although you may need to get a referral from a doctor as well. But they can help you to understand what's available within your community. So that's 211. The health authorities, depending where you live, here on Vancouver Island, we have Island Health, and we've got a primary care memory clinic that does a lot of referrals now. I've worked closely with them to let them know about some of the community-based programs that I'm trying to develop. But they've got social workers and OTs with expertise. OTs are important because they're used to addressing functional limitations that have to do with work or have to do with managing daily activities. Physical therapists focus on mobility. So if your family member's having a mobility walking issue, falls, a PT would be appropriate. Social workers can help you navigate and can help you find the appropriate resources and do referrals for home care or let you know where the adult daycare is in your community. So the healthcare authorities are a really excellent resource. And oops, I think I had another bullet there that needed to be edited. Apologies. Okay, I wanted to just close with something that shows, I think, the power of staying engaged and the importance of it. Whoops. Why is that doing that? Oh, here. Sorry. So this is I mentioned a dementia choir that I founded and did research on. Oops, I'm having trouble on my, and this is an example that we did during COVID. If you ever find yourself stuck in the middle of the sea, I'll say the word to find you. If you ever find yourself lost in the dark and you can't see, I'll be the light to guide you. We find out what we're made of, and we are called to help our friends in need. You can't come on me like mine. I'll be there. And I know when I need it, I can count on you. I will be too. You'll be there. 'Cause that's what friends are supposed to do. Oh yeah. Ooh, ooh, yeah. Okay. Oops. Okay, so that's, I think that Zoom that we did during COVID and made that video showed how we managed to keep a community going even during COVID. We met outside, and I think, but beyond COVID, it shows the importance of community and how much people enjoyed being together and the importance of that. So I hope that leaves us on a positive note because so often talking about dementia can be kind of challenging, huh? Okay, let me see if I can get back to my Zoom. I'm muting.
Thank you so much, Deborah, for that presentation. What an excellent overview, both high level and more thorough, about what somebody might be able to expect with risk factors, receiving that diagnosis, the steps to take who to reach out to, building that community of support, as well as touching on some of the new treatments and new progress coming our way. So thank you so much for that. I do have a few audience questions that I'd like to address. So without further ado, let's go ahead and get started. So to begin with, this audience member is curious about if someone doesn't have a circle of support, like a partner or a loved one, whether they're simply not there in the picture or they're very difficult to get in touch with, perhaps they're across the country, what professionals or groups, organizations that might exist to fill some of those gaps for that person?
Yeah, I think you should really reach out to the Alzheimer's Society initially, your local branch, and find out if they have any coffee and chats and how they can help connect you with other groups that might provide some support. It's an excellent question. The challenge is it's going to vary depending on what community you live in. And here on Vancouver Island, I'm working really hard to develop resources here in Victoria, and I'm trying to replicate memory cafes in Vancouver and over on the mainland. But we don't have a lot up island. And so people up there don't have, it's just the fact of living in a rural environment. So it's definitely going to be more challenging. You definitely, if you don't have a care partner near you, you need to really prioritize um, the care planning. And you can do that a bit with a social worker who can really help you identify who can help you specifically with certain aspects of that care planning and how you can get engaged in your community. The worst thing you can do is to withdraw and to become socially isolated, quite honestly. So definitely address that and then begin to address the legal and financial issues because you don't want to run into problems there. Thank you for that question.
All right. Next question. This audience member asks, what are some of the key things that I can do to prolong my independence by living at home?
Yeah, I think it's going to be mainly lifestyle, like making sure you exercise, making sure that if you're having any falls, that you get your home assessed by a occupational therapist, that you're eating a healthy diet, minimizing or avoiding alcohol. Just those things really have an impact on how fast. So even if you have a dementia diagnosis, like you can change that trajectory by changing your lifestyle. And again, the social connections. Now, we all have a different need for social connections. Some of us are more introverted, like myself. Um, but to have a group of people that you laugh with, that you have fun with. Um, I have a group, we do cold water, we're called Cold Water Addicts, and we go down every morning at 8 and jump in the ocean. And it's so amazing to me. Like we have people in their 80s and they use canes and it's a rocky, uneven beach. And I'm sure some of them are having memory issues, but they come down and we help them into the water. We all walk in arm in arm and they have so much fun because we're laughing and screaming a little. And we're only in for about 8 minutes maybe, and then we all leave. But it's amazing to me, like that community, how they support one another. So finding something that you really enjoy doing, if it's gardening, and finding people that support that, that's your social connection piece. So begin to look at what you can do to, just create a high quality of life for yourself. And that will definitely slow things down and also make you happy. And that's good. That's important. You don't want to fall into apathy and depression.
Yeah, absolutely. Thanks to the audience member for that question. Next up, this audience member is curious, in your experience and your research, what are some effective ways to get a patient to accept help with activities of daily living? So maybe this individual is a bit resistant about their growing need for additional supports or the impact of their diagnosis. What are some ways that you might coax or better support that person?
Oh, that's a great question. And just so apropos, I spoke with two family members this week who want to bring their family member to one of my memory cafes, but they said, "Are you going to talk about dementia there?" Because, he's in denial or he doesn't want to talk about it or she doesn't want to talk about it. And so not making dementia the focus, I think is can be really helpful. Like I say to the family members, we don't talk about dementia. We're here to have fun, connection, learning. Um, and so it's not the focus. Dementia is one aspect of who that person is, and we want to get to know them and what they're like and just have fun together. So I think, as someone, it's tricky. It's really tricky. You know, not making dementia the focus and then trying to find um, ways that you can support them and help them see that their life would be better if they had a little bit of help in whatever area it's in, like help keeping your house clean or not having to cook every night. Or, I don't know if you're talking about someone living alone. My mom, for example, I gave that example of my dad not liking to have a bath. And yet, when someone new came in, she was astonished that he just followed her right down the hall. And so sometimes, like, just trying something, it depends. If you have a family member, it depends where they're at with their memory loss. But also, I think talking with social workers who have great social skills and understand how to navigate this difficult thing. It's the stigma of dementia that makes it so hard. People don't want to talk about it. They don't want to think about it. They don't want to believe they have it. There's a lot of denial out there. I can't have this. I'm fine. So moving them beyond that's going to take getting them into a space where it isn't the focus, but you're helping them to have the quality of life that they want to have as opposed to just withdrawing.
Thank you. In relation to this topic, we had an audience member ask about how to encourage and motivate a person that might be coming up to that dementia diagnosis or suspected diagnosis, or maybe has just been diagnosed. And you spoke about stigma as well. I wonder if you have any strategies about encouraging, motivating, supporting that person outside of perhaps the ADLs, the physical tasks, the logistics that someone needs.
Yeah, that's where it's going to take really looking at some of their social connections and the things that they've always liked to do, and how can you support them in continuing to participate. I started the dementia choir because people like to sing, and many of them sang in church choirs or in community choirs that required that they not have a notebook in front of them. And so that wasn't very inclusive. So forming a choir where you could hold a notebook and where you had a student next to you so that if you had trouble finding your place, those are the kinds of programs we really need. And, like if you don't have anything, like if there's challenges to continuing to participate in community programs for your family member or person living with memory loss, I would say talk to the organization that's offering those activities and say, how could we ensure that this is inclusive? He really loves doing this. He's struggling with this. Is there a way that I can support this? Do I need to come with him or her? Is there a volunteer we could assign to make it fun? Because you really want people, you want to normalize life, I would say. You want to normalize life, and the reality is things are going to change and over time, but don't focus on, like that you're going to need more and more support or any of that. Like just say, here's how we can help you continue to do something you really enjoy. So I think it's key. And then, I'm hoping that programs become more available that are more inclusive over time. But we're going to have kind of a groundswell working on that for that to really happen. And I know caregivers are overwhelmed, but knowing what resources you have in your own community that can support your family member that has memory loss, what are the fun things that are still available to him or her? Because you don't want to just be sitting in front of your TV in the corner of a couch all day. It's not, you need engaging activities where people are tapping into memories, where they're laughing and having fun. All that stuff is good for your brain.
Thank you. As a follow-up question for that, looking at, what we just spoke about of individuals that maybe have already been assessed and have found to have a diagnosis, let's talk a little bit about somebody that maybe refuses to acknowledge that they're experiencing memory loss that's outside of what you might anticipate for active aging. This audience member is curious about when do you step in? How do you respect that individual's autonomy, dignity, independence, but also recognize as a loved one or a substitute decision maker or a caregiver that intervention is essentially needed, whether that's testing or additional supports?
Yeah, there's no easy answers here. It depends on your relationship with that person. Um, there's key risks that, like, I've had a friend who kept burning up pots on her oven. She's in complete denial about her memory issues. She's crashed her car. I finally did an anonymous report to her doctor. I happen to know her doctor and said she really needs to be tested. That's really tough. If she ever finds out that that relationship's not going to go well, but at risk was that she would get in another accident and harm someone, or that she could burn down her kitchen. Not a lot has changed. It's going to take, I think, a few, you know, you have to look at how risky it is, what's happening. We want to respect people to a certain point. You may want to reach out to other family members and see if they can help. In this case, it's a friend, so I'm a little bit who lives alone, who lives across the country from her family. So I'm struggling with what needs to happen here. And it's, I think reaching out to her medical provider was probably the best thing to do at this point. Um, but yeah, people are in denial. The thing people are most afraid of is being diagnosed with dementia because there's so much stigma. And so they avoid that until the last possible moment, which leaves very little time for planning, for getting a plan in place, and for perhaps getting some treatments that might change it. Or, it's always possible too that it's something that's reversible. So you might be able to use that. Like, hey, I've noticed that there's these things happening. Maybe you should consider having your doctor assess you, because it may be something reversible that's treatable. And it would be a shame to have this continue if it can be treated. Um, yeah, it's difficult though. It takes navigating the relationship with a lot of sensitivity. And you kind of have to assess how much you're willing to stick your head out, is someone else in danger? Are they still driving and they should be? That's crucial to address. Every time I'm on the road, I'm thinking, I wonder how many people are driving that really shouldn't be. Um, there's a certain subset that drive beyond when they should, right? They don't want to give up their keys. It's such a sign of independence. So I think thinking about ways you can normalize their life without um, infringing too much, but also encouraging them to begin to recognize that they're struggling a bit, and maybe talk to a social worker to get some help on how specifically to address the concerns that you have, because it's a very specific kind of issue usually that people want to that makes people want to intervene.
Yeah,
Hmm,
absolutely.
it's
So
tough.
we have just a few more minutes left here. So we're going to wrap up with two final questions. Very quickly, this audience member is curious. One, do I need to be assessed by a specialist, such as a neurologist, in order to be diagnosed with a dementia type disorder, or could that be through a general practitioner? And then, as a follow-up, in our last question, if you could change one thing about how people understand dementia and other types of memory loss, what would that be? So we'll start first with the specialist question.
Yeah. So initially, you'd probably go to a primary care provider and just mention concerns that you might have. Like if I went in and said, I've noticed I'm having more difficulty, I'm concerned about my memory, and they would do like a cognitive screen. That's pretty straightforward. And they'd probably screen for depression too, because depression can affect cognitive function. So they'd do an initial health assessment and determine what screening tools they want to use. And then you'd probably get a referral if indeed it does seem like it's a challenge. In our case here in Victoria, we've got a primary care memory clinic that's open a couple days a week. People often get referred there for a diagnosis because there's a neurologist who runs that um, center, and it's pretty well organized so that if you are diagnosed, you get referred to a social worker who follows up and helps you begin to do some of that planning. Um, Your primary care doctor, if you don't have a primary care memory clinic, may refer you to um, a neurologist directly, but that can take months to get a diagnosis, to get that referral. Sometimes, like we have a seniors outpatient clinic as well that handles more complex geriatric patients. They can certainly do a diagnosis also, and it might be faster to get referred to a geriatric outpatient or a seniors outpatient clinic. Um, but your primary care doctor is a good place to begin with because they can do some initial screening with some labs and some simple tools to check your memory. Um, some of you have probably tried some of those tools on Facebook, but those are not validated. But it's really worth getting assessed earlier rather than later.
All right. Last question. If you could change one thing about how people perceive and understand dementia type disorders and memory loss, what would that be?
Yeah, it would definitely be just recognizing that the tendency is to withdraw and to sink into apathy. And it's so important that you find a community that you have fun with and normalize your life as much as you can. That's what's going to keep you independent and active. And also just to that there are so many things that you can control. Those 14 risk factors, there's a number of them that are very modifiable. Your diet, managing your health well, your hearing and vision loss. People are often very resistant to getting hearing aids. They're too expensive. I don't need them. People are mumbling. No, you need to get your hearing tested. I started getting mine tested at age 60. I'm fine so far. It's so insidious. We don't realize that we have hearing loss until people are getting pretty irritated with us. So those simple things like managing your health effectively, activity, diet, um, medications for health conditions are so important. And people don't realize you can control those things. So be empowered and do what you can. Even if you have a gene for dementia, the APOE4 gene it doubles your risk. There's ways to lower that. And having a risk factor doesn't mean you're going to get dementia. So recognizing that as well. Um, if I were, I've had genetic testing and I highly recommend it if you're ready to deal with the truth, but I would rather be looking for the signs and symptoms that there may be a cognitive issue than waiting for someone else to have to tell me. So I think doctors should be screening everyone after age 65, like every couple of years for cognitive loss, and they don't. We've got these arbitrary age-related things like, at age 80, you have to be cognitively screened to continue driving. But we should be doing it earlier than that, probably 65 or 70. Why not? And then it's routine and we're catching it and people aren't gonna, they often don't want to ask to be screened. They're scared. And I get it. None of us like those cognitive tests. I'm going to tell you 3 words, and then 10 minutes later they ask you what those 3 words are. It's crazy making, but it's important because you need to take control.
Yeah. Well said. Take control. All right, everybody, that's all the time we have for today. Deborah, I want to thank you so, so much again for your time, your hard work, your efforts, this fantastic presentation covering the progression of essentially anything you might need to know about dementia. To our audience members, thank you so much for your registration questions, your questions during live. We hope you found this webinar worthwhile. It's thanks to the generosity of our supporters that we can continue to provide webinars like this, as well as all of our compassionate services 100% free of charge to people across Canada. In that vein, we ask that you please consider paying it forward and empowering us to continue the work we do by making a donation today. Thank you so much for your support. Without further ado, thanks again, everybody, and have a lovely afternoon. Bye bye.
Thank you, everyone.